Yeah, so obviously laser atherectomy was the first tool to receive approval for the treatment of in-stent restenosis, but with an older device. And now there's a new device that's come out, and this is called Turbo Power. It rotates about the wire with an eccentric wire lumen. But one of the problems we've always had with laser, bare excimer laser energy will actually cut through bone. But laser catheters typically would not. Why is that? Well, with these fiber optic fibers, you can see there's dead space. And there's also metal cladding around, which is not going to ablate through dense calcium. So by rotating this device, we're negating all dead space. In addition to that, this is allowing us to create orthogonal displacement of friction. And so lesions historically we could not treat that were calcified, we're finding that we now can treat fairly effectively. I think you would all agree this is a pretty severely scarred, densely calcific common femoral artery. And this is the angiogram there. This is certainly severe dystrophic calcium. It does also involve the profunda. This patient was turned down for surgical endarterectomy because he had had 3 prior endarterectomy attempts and there was dense scar. So we're going to look, and this is the distal vessel, again, more calcium. The patient did move, but we figured we could still use this, and you see the device as it's rotating through this densely calcified lesion, moving very easily. Historically, we would have never tried to use laser on densely calcific lesions like this. I failed to include the IVUS pictures, but it showed intraluminal calcium, not just external calcium. And here we can see the device. I just wanted to let you see how it spins back and forth. Now, we then address this densely calcified SFA and popliteal segment. You can see it spinning through here. It's going through nicely. And you can see now we've had substantial improvement in the common femoral artery. And in the SFA, not perfect, we balloon this. We balloon the common femoral. And now we have a fairly widely patent vessel, but this posterior, but this profunda, we also wanted to clean, and we did not want to have plaque shift. So we lasered that first, and then we ballooned this. And you can see what kind of result we had. And this is just simply laser and balloon with a drug elution balloon, a wide open common femoral, and SFA treated with drug elution balloon. Now the beauty of this case, this entire case from beginning to end was a 15-minute case. And short of the fact that I wanted to show you the laser moving, I could have done most of this with no radiation exposure, simply advancing. Now what about ISR? This is a totally occluded in-stent restenosis. I was one of the principal investigators along with Eric Dipple for the treatment of ISR, but we had problems in that trial. We were supposed to make 4-quadrant passes using something called the turbo booster catheter. 4-quadrant passes were not made in most of those cases because this was a bulky device. It grabbed onto lesions. So we really didn't achieve optimal debulking. Despite that, it was clearly far superior in both safety and efficacy to standard balloon. But do any of us believe that the treatment is simply atherectomy alone? Of course not. It's atherectomy and drug elution of some sort, or atherectomy and a covered stent of some sort if there has been stent disruption. So perhaps the best of the studies there was a study done by Gondini, and I did not include it here. But Gondini's study looked at using a drug elution balloon alone, because remember, we just heard 90% patency numbers reported, but those were short lesions, versus debulking first with laser and following with the drug elution balloon. What do you think did better? Laser debulking followed by drug eluting balloon had twice the patency of using a drug elution balloon alone. I think it makes sense that we need to remove tissue. Now this is a long occluded SFA stent. It's very long, about 40 centimeters. And here you can see nice distal runoff after we cross this. This was fairly acute symptoms, so we did put a filter here. You can see after turbo power alone. We have some debris in this filter. So we are going to balloon. We're going to drug elution balloon after making this channel. We're going to remove the filter. And this is pretty standard of what one can expect after laser and debulking. Now, what is important is in this entire trial, we did not see a single case, even using this bigger, bulkier device on in-stent restenosis. We did not see a single new fracture. We saw no new separation of stents. And certainly we had better results. You may ask, why was this not compared against drug elution balloon? Or why was drug elution balloon not included? It's real simple. Drug elution balloon was not approved for the treatment of in-stent restenosis. And you cannot compare two investigative modalities at the same time, because if you do, okay, one does not know which is creating the effect we had. So the EXCITE trial was against standard balloon. But what Gondini did and his predecessor in terms of looking at this, Joost Vandenberg did, was to look at laser debulking first, followed by drug elution balloon, and the results were phenomenal, 90% plus patency a year out. This is very important. So what's the difference of this new device? Well, it's a lot. We're getting much more luminal gain by rotating around this eccentric lumen, and it rotates 180 degrees and back. It doesn't just keep drilling. We're having far more luminal gain. We're making much bigger channels, and they tend to be round. Secondly, rotation negates the dead space. Again, remember, there was dead space between the fibers, and there was dead space caused by the cladding around the fibers. And finally, something we've all known about is orthogonal displacement of friction. As we go through a very long area of occlusion, there are frictional elements there. This allows us to displace that, but there is another thing going on here. As this is making a bigger channel, it is allowing the gases that we're creating as we photoablate to escape rather than go into the vessel wall and cause a dissection. So actually, in all the years in which I've been using laser, I really think turbo power is the single greatest advancement that they have made. I think it will change the applications of laser in general. I thank you for your attention.